So, hey there, everyone. I hope you and your families are doing well during this crazy time. So, I just wanted to come to you today as kind of a follow up for the presentation that I did yesterday on really going over the parasternal long axis protocol. So, now I'm going to go through some echo images with you here, some live images that I did, and just kind of point out some things to you. And hopefully, this will help some of those things in the book make more sense, so you can kind of put that to real life images that we're going to see each and every day. Okay, so if you want to go ahead and pull out your protocol again that I gave to you, and as I said to all of you, I did upload another protocol into Schoology that started the parasternal short axis at the base instead of the apex. The one you had previously started at the apex. So I just reconfigured that to start it at the base, which is what we've been teaching you all during this class. So here we go, starting out. So here is your basic parasternal view here. And again, we have our increased depth view that we found here to begin with. And if you look over, our scale is over here on the right. Okay, so we are at about 15 centimeters here with our depth. And it doesn't really matter, what the scale looks like. We just really want to be able to see all this area here kind of posterior or inferior to the heart right here, all this entire area right here. So we right here, we see the descending aorta. All right, so we definitely want to see some space below that. And again, we want to rule out that there's no fluid either around the heart or around the lungs in this view. And at the same time, too, though, while we're paying attention to that, as I've said in the past, when you get your parasternal view in there, you want to get a good, nice 3 beats of everything looking nice. The ventricle is open, both valves you can see opening and closing. So we don't want that image going out of the screen and back in, or one of the valves closing off and not opening back up, or the ventricle, same thing. So we want that everything nice and open the best that we can get it. Now, as we move forward, we've come back to our normal depth here. So you can see we're right at about 15. I think maybe I put as a estimate on your protocol around 16 or something along those lines. But all that depends on how big the heart is and how deep you have to image to get to it. So here you can see, we see our descending aorta at the bottom of the screen here. We still want to keep that into our view, okay? So that's kind of right where we want to be. Again, the ventricle is nice and open throughout each beat. We can see both valves opening through each beat, and the heart is not coming in and going out on breathing on this screen either. So this is our nice parasternal long axis view at our normal depth there. Now we're going to go into our measurements. So like I told you, it shows in the book measuring your RV right here also. This is not something that we're going to do as part of our class. You may get in an echo lab where you see people that are still measuring the RV right here, and that's perfectly fine if they're doing that. But just know that we're really not getting any good information out of that measurement. The best way to measure the true right ventricle is going to be in our apical four-chamber view, and we will measure it there. But this is really our right ventricular outflow tract view, proximal RVOT right here. It's not really our true measurement of the right ventricle, okay? So we're going to start right here. Okay, we want to make sure we get right here on the line of the interventricular septum. Okay, you see this little area right here. This is a little portion of kind of like the commissure uh, or the annulus of the tricuspid valve, kind of with what you can see right here. So we don't want to include that in our measurement because that's not, it's not part of the interventricular septum. Oftentimes, too, here you can see a little layer of the RV muscular portion of the wall, and we don't want to include that either. So it's very important we try to get right on the line where we see that interventricular septum come in. So we start there, and we're going to come here right to the bottom line of that interventricular septum. And so you see the plane that we're on right here, we're coming straight down. Okay, now we're going to come from the septum to the very beginning of the posterior or inferolateral wall, which is right here. Okay, so if you notice, this is a chordae tendineae coming across right here. We've got another chordae tendineae coming across right here, attached to our papillary muscle over here. So we want to make sure we're not including those in our measurements. So here you can see this little black space in between that chordae and the wall. And so right here, this is the wall, the beginning of the wall of our left ventricle of our inferolateral posterior wall. Okay, now once you start seeing this really bright line here, that's our pericardium. Okay, and so we want to stop right at the edge of that bright line right in there, and that's going to give us the wall thickness for our interventricular septum and for our posterior wall. Okay, bear in mind these images are during diastole. Okay, so if you see here, we have just scrolled basically to when the mitral valve closes. Right when it closes is when we want to take these measurements. So we're getting ready to, both valves are closed, so we're getting ready to be in our isovolumic contraction time because the ventricle is at in diastole, so it's getting ready to start systole. But we're just not quite there yet. So we want that mitral valve to be closed. That's when we do this measurement. In addition to that, we're going to measure the aortic root right here during diastole as well. Okay, the aortic root, we kind of want to go from the leading edge of what we see up here to the leading edge of what we see down here. Okay, now in the book it talked about you can zoom in on the aortic valve to get, or the aorta to get this view. That's certainly something that some people do. If you can see it well right here, you can certainly measure that, but we can also get it in another view or zoom in on it if we want to get a better look at it as well. Now let me go back one clip right here, and we can pause this, and let's see if I can, I don't know if I'm going to be able to scroll this forward or back. No, guess not. Okay, guess I'm not going to be able to scroll back there. Let's see, maybe I can go back a frame here. There we go. Okay, so now let's look here. Now we're going to go through our cycle right here. Okay, so right here, mitral valve's open, right? The mitral valve is open. So we know that's diastole because the mitral valve is open. So that's allowing blood flow to go from the left atrium to the left ventricle. Now we're going to keep scrolling forward. Okay, valve is still open. Now just open wide, so that's going to be our atrial kick, and now it's closing. Okay, now that valve is closed right there in that frame. The aortic valve is still closed. So right when that mitral valve closes, let's go back a frame, still open a little bit, closed. That's where we want to take our end diastolic measurements right there. Okay, and that's what we've done there. And now moving forward, we're going to get our end systolic measurements. Okay, so let's go back to this clip here. So we've taken, let's say we've taken our end diastolic measurements right there. All we're going to do is simply scroll forward with our trackball because we've frozen our image, so we can scroll forward now. Ventricle is squeezing, squeezing, squeezing. Okay, it's pretty much at its peak, just about right there. Okay, now it's starting to relax again. Now mitral valve opens, so we know we're back in diastole there. So we really just want to come to peak systole where we see that ventricle squeezing at the the highest amount of squeeze that we can get out of that ventricle. That's when we want to take those measurements, which is going to be like right there. Okay, so that would be peak systole. That's where we're going to measure, do all of our systolic measurements kind of right in that area. And let's go forward here. Okay, so here's peak systole for us. We've taken that measurement of the ventricle. Okay, we're measuring the left ventricular outflow tract right there as well. So we look at where the cusp insertion point is for our cusps. We come this way a few centimeters and we measure right there for our LVOT. Again, this is another measurement that we may want to zoom in on to get a better look at it to make sure we're measuring it properly, because this measurement plays a huge role when we're evaluating our aortic valve area. All right. The other measurement we get here is going to be our left atrial measurement. So you just kind of want to go from inner edge here to inner edge here to measure that left atrium at its largest there, okay? These three measurements we get during systole, okay? So we've got our diastolic measurements, systolic measurements. All right, moving forward, then we're going to slide up a rib space or two. We're going to elongate this aorta, and then we're going to measure the ascending aorta up here, okay? You want to be up in this area, so we know we're in the ascending. We don't want to be down here because this is still kind of the aortic root. In your book, they also mentioned measuring the sinotubular junction, which would be about right here. That's kind of when the root itself kind of comes down and starts to form the ascending aorta. That would be right in here. We don't routinely do that measurement, but here is our ascending aortic measurement, and we go from leading edge to leading edge to measure that. Okay, so that's really all of our 2D measurements that we're going to do in our long axis view. So we've done that. So we've done all of our measurements. Now we're going to go to what you all are a little bit more used to doing here. The next thing we're going to do is we're going to zoom in on the valves, okay? So we can take a little bit better look at those valves, all right? So if you can get the mitral and the aortic valve in at the same time, you can go ahead and zoom in on both of them. Sometimes you simply can't see both of them opening and closing well at the same time. So we may have to zoom in on the mitral valve and then kind of angle a little bit differently and go up and zoom in on the aortic valve after that. But perfectly fine to do them individually, but if you can see them at the same time, go ahead and do both of them at the same time. Same thing with color. We're going to do color on both valves. You can do this individually as well, but if you can see both at the same time, go ahead and color both. And notice our color box here, like I've told you, it's fairly narrow, okay, but it's still covering both valves. If we look over here, our frame rate with our color is 23, which is good. We really want to be somewhere around 16 or 17 and above on our frame rate. All right, so we've got both of those valves in, got a good 3-beat clip there. Now we're going to go and color the septum. So as I told you all in the past, it doesn't matter too much about how long your box is, just as long as it's narrow. It's still wide enough to cover the structure that you're trying to look at. So our frame rate is still nice and high there. Frame rate's up there around 31. So we got a really nice frame rate there. All right. So we've colored everything we need to color. Now we're going to go do our M-mode sweep. So we're going to cut right across the aortic valve there. Okay. And we want to try to get our nice box that we see right here. That's the aortic valve open, closed, open again, closed, open again right there. We got 3 beats that we're seeing it open. That's what we want to see. And here is our mitral valve waveforms. Okay, we've got our E and A wave, E and A, E and A. We see nice 3 beats there. That's what we want to see. And then we've got our left ventricle measurement, and you're going to place your cursor right over the same area that you would want to measure the left ventricle like we did before. And you've got systolic beat here, systole here, and another systole right there. So a good 3 beats again. That's what we want to see. All right, then we're going to move forward to our RV inflow view. So as we know, we're going to tilt our tail toward the patient's left shoulder and try to bring this view in. You may have to drop down a rib space or so, just kind of depending. But however you can see this valve the best is where you want to be. And ideally, you would like to see this anterior leaflet and the posterior leaflet coming in there well, okay? This little section here, that's a little remnant of a eustachian valve. Okay, and our inferior vena cava is right here. Our coronary sinus would be right up here. Okay, the superior vena cava, even though you can't see it, it would be coming in from this side up here. All right, so that's our view. We get a nice 3-beat capture of that. Okay, now we're going to color right over top of that valve. We want to get our color box big enough to come down here into the atrium as well. Okay, we see our frame rate's 23 with our color. That's good. See color going through there. We don't really see any regurgitation when that valve closes, but we're still going to put continuous wave through there. With continuous wave going through there, again, like I said, we don't care too much about the forward flow through the tricuspid valve, so we don't need to measure that. Okay, but we're going to take our baseline up. We're not going to take it up all the way to the top, so we still want to see a little bit of flow up here. But really what we're looking for is we're looking for any kind of flow down here in this area. And we really don't see any because there is no tricuspid regurgitation. Okay. A good rule of thumb to start out is to get your scale for your tricuspid regurgitation somewhere around about 2. Even if they do have mild tricuspid regurgitation, it's probably going to be somewhere around about 2. So that's just a good rule of thumb to kind of start our scale off right there. Okay, now we're going to pull in the RV outflow. We're going to tilt the tail the opposite way down toward the patient's feet. And here we can see a good shot of our pulmonic valve right here. Pulmonary arteries coming down this way. Okay. All right, here's our color flow through there. Again, we want to try to color the entire area of what we're seeing here, not just the valve, but we want to color down here in the pulmonary artery. Okay, there's just a little tiny whiff of pulmonic insufficiency or regurgitation right there. Okay, we're going to go ahead and put our continuous wave through that. All right, and as I said in the past, we want to bring our baseline somewhere around about the middle because we want to see if there's any regurgitant flow up here, which you do see just a little trace amount here. But we also want to see forward flow here too. Okay, so from a measurement standpoint, what we're going to do now, we're going to click on our measurement that says pulmonic valve VTI, which stands for velocity time integral. We'll talk about that more in the future. But essentially, all that measurement is just tracing this waveform here. Okay, this is our forward flow going through the pulmonic valve. All right, and it's going to give us, by doing that, it's going to give us a max velocity, a mean velocity, and a max and mean pressure gradient going through that valve as well. Okay. And I took this picture. Never mind. Okay. So what we're going to do here, we're then going to turn on our pulse wave. All right. And if you can see the cursor right, here's our sample gate. Okay. We want to put that sample gate right up above the pulmonic valve, right before that pulmonic valve is opening. So we kind of want to be in the RVOT to make this, to take this sample. So that's what we're doing here. We're worried about flow going through here. We don't use pulse wave to look for regurgitation, okay? All we do, with pulse wave, we just look for flow going through things. We don't look for flow coming back the opposite way. So with this, we can take our baseline up closer to the top because this is what we care about. We care about flow right before the pulmonic valve. And we're going to do the same thing. We're going to trace that, all right? And then we're going to do another measurement called pulmonary artery acceleration time. And we're going to put a little cursor here. And then we're just going to slope down to the point of that waveform right there. We'll go over all these measurements again in the future, but I'm just trying to show you exactly what we're going to do in each and every one of these views. So that gives us an RVOT, max velocity, mean velocity, max pressure gradient, and a mean pressure gradient going through that valve. So we look at flow right before the valve, and then we look at flow through the valve. That helps us to determine if there's any type of stenosis, or basically stenosis is when the valve is not opening properly. So if we look at flow before it and we look at flow after it, we'll kind of know one way or the other, because flow before the valve should be similar to flow after the valve, unless the valve is not opening properly. If it's not opening properly, flow after the valve is most certainly going to be higher than flow before the valve because it's trying to fit through a much narrower orifice. Okay. We move forward with our parasternal short axis base view here. Okay. Now we see a lot of different structures here. As we know, the main thing we're focused on first is seeing that aortic valve. We want to see 3 cusps to the valve. We want to see our right, our left, and our non-coronary cusp. As I've said, the non-coronary cusp is always going to be closest to the interatrial septum here. All right, so we have our left atrium here, interatrial septum, right atrium, tricuspid valve. This is our medial, or it's also called our septal leaflet, and this is our anterior leaflet. Okay, the right ventricle, sorry about that, zoom back out of that. The right ventricle is wrapping around this way. Okay, can't see it well here, but our pulmonic valve is right in this area here. Pulmonary artery is coming down this way. Okay, and we're going to zoom in on the aortic valve. Again, we want to see 3 leaflets or 3 cusps to the valve here. We see that there, so that's good. Then we're going to color the aortic valve there, looking for any regurgitation. Then we're just going to slide that color box over to the right side. Now, to get this right side in, sometimes you may have to manipulate your view a little bit. Maybe you need to go down a rib space or up a rib space or over a little bit. It's not always going to come in, not everything is going to come in perfectly in this view all the time. So sometimes you have to go around and find things that look a little better. Okay, so we put our color box over our tricuspid valve. We also want to color the interatrial septum right here as well, because certain times if there is an ASD, an atrial septal defect, or a PFO there, we can potentially see color flow crossing there. All right, and then we're going to move forward. We're going to put our continuous wave over that tricuspid valve again, looking for regurgitation. Right here is where our valve is closing, this white line here. If there were regurgitation, we would see a waveform coming right behind that. We don't see it there because there really is no regurgitation. So here is the pulmonic valve. So in this view, again, like I've said in the past, a lot of times it's tough to see these valve leaflets for the pulmonic valve. It's okay if you don't see them all that great, but we do put color on there. We see nice color flow going through there, and that's really what we want to see, okay? So now we're also going to put continuous wave through this valve here again, but because we did these measurements already in our RV outflow view, we're not going to measure it again, but we're just still going to show it. So we can just say that we did interrogate this valve in 2 views. Now, if you can't get the RV outflow view in very well, and you can't see things well in that view, then you may end up having to measure it in this view if you can see things a little bit better. So one or the other, either measure in the RVOT view or measure in the this parasternal short axis view. All right, and now we go on down to the mitral valve. We want to see the anterior and the posterior leaflets opening and closing well there. The ventricle's nice and round here. That's what we want to see. We're going to put color flow through that valve right there. But again, we're not going to measure anything there because we're not parallel to flow. We're almost kind of looking down the barrel of that valve. So we're not, our parallel to flow would be kind of coming this way, and we're not that way at all. We're almost perpendicular. But at times, if we do have an eccentric jet of mitral regurgitation, we can sometimes see it jetting out one side or the other in this view. So that's why we color it in this view also. All right, now down to our papillary muscles. I want to see the anterolateral and the posteromedial papillary muscle here. Okay, nice round ventricle, and then on down to the apex. As all of you have kind of demonstrated, sometimes we have to move down a rib space or 2 to find the best apex shot of the heart. See everything squeezing in there well. You don't see any papillary muscles anymore, and that's what we want to see. Okay, so this is basically taking us through exactly everything that you will do from here on out in your parasternal view. All right, hopefully this is helpful to you, and you can just kind of go back and forth through this to familiarize yourself a little bit more with what we're going to be doing in the future with this protocol. And I may move forward with this and do another lecture on it, depending on how much longer it's going to be before we're able to meet in the classroom. But I will let you know for sure one way or the other. The other thing I would like to share with you is, I do want to make it clear, we've talked about this a lot in the past. So going back to our 2D measurements, okay, when we're in the parasternal long axis view. We want to make sure that we are measuring on axis with the ventricle. I can't stress that enough. So right here, our ventricle is basically on this axis here. We're coming kind of straight through there, okay? This is kind of the axis we're on, all right? And we want to measure as perpendicular to that axis as possible. So when we're doing our measurements for the LV, we're going to start right here for the septum, come down this way, and then we're going to come right down here and measure our posterior wall right there. So we're kind of cutting this so at a 90-degree angle. We're measuring basically perpendicular to our axis here, and that's what we want to be. Now, if we, sometimes we can't see the heart really, really well if we're on a certain rib space where the heart is truly, perpendicular. Sometimes we have to drop down a few rib spaces, and when we do that, the way the ultrasound beam is hitting the heart and the way that it's showing us on the screen is it kind of cocks the apex of the heart up like this, okay? Sometimes this may be the only or the best view that you can see the walls of the heart to really be able to measure it. And that's okay if that's the only view you have, but we always want to make sure, go up a couple rib spaces and check it out and just make sure you don't have anything more on plane like this. And then come back down if this is all you've got and do everything from here, okay? So here our axis is essentially coming like this. So we certainly don't want to measure coming down like this. We don't want to measure from the wall here to wall here, coming down this way, here to here. That's not going to give us a true measurement. That's going to make our left ventricle much bigger than it really is if we do that measurement. This is the whole reason why we say in-mode measurements aren't that accurate for the left ventricle anymore, because your in-mode has to come straight down like this. Your in-mode can't come over here and measure it on axis. So if you measure this with in-mode, it's going to do your measurement from here and it's not going to be accurate. So you're going to give the patient a large left ventricle when they essentially don't have a large left ventricle. We want to come from this axis right here because that is perpendicular to the true axis of the apex of the heart right here. So we're going to do our measurement there. We're going to measure here, and we're going to come down this way, and then we're going to measure our posterior wall there and posterior wall there. All right, so we're truly perpendicular right there, and that's what we want. I can't stress enough that you want your measurement to be in between that papillary muscle and the posterior annulus of the mitral valve right there. And you want to be sure to not include any of your chordae tendineae in that measurement, all right? And again, over here, we want to be from right here to right here. Right in the middle of that is where we want to make that measurement. And we don't want to include any of that, okay? And we want to be perpendicular right there, all right? So we want to come straight down that way. That's going to give us our most accurate measurement of the left ventricle, and that's where we want to be, okay? Again, hopefully this was helpful to you. I will be in touch with everyone again in the very near future. Hope you all have a good evening, and I hope everything is going well for each and every one of you and your family.